Hi friends. So in this session, we are going to focus on few more classic GI tract related conditions and hepatobiliary conditions. So mainly we are going to look at some bowel spotters and clinchers and focus on hepatobiliary imaging. This is something which is again an absolute favorite topic in your INI-CET exams. So look at this question which was asked. A post-cholecystectomy patient presents with a collection in the Morrison's pouch or subhepatic space. A biliary leak is suspected. So the suspected diagnosis the examiner has given you. Which is the next best investigation? What do you do when you suspect biliary leak in a post-operative post-cholecystectomy patient? Would it be MRCP, ERCP, HIDA, CECT? Now let us compare these HIDA scan, MRCP, ERCP, right? So what is HIDA scan? It is hepatic immunodiacetic acid scan. We are going to discuss it going ahead. Magnetic resonance cholangiopancreatography, MRI technique for visualization of the biliary tree. ERCP, endoscopic retrograde cholangiopancreatography. So will each of these studies show you a leak? Yes, they will show you extravasation of the biliary secretions, they will show you a leak. But which of these would help you identify the precise site of leak, whether it is in from the say common hepatic duct or the cystic duct or the common bile duct? What is the exact site of leak? Well, HIDA scan, because it has a very poor anatomic and spatial resolution, it won't help you identify the site of leak. So that is one limitation of HIDA scan. Nowadays HIDA scan is not done because there are more accurate techniques which are available. MRCP, depending upon where exactly the main focus of the collection is, can help you identify indirectly, right, the site of leak, right, though not a direct visualization would be possible in MRCP. ERCP, when you actively inject contrast within the biliary tree, it will show you the actual site of extravasation, so would be the most definitive technique for evaluation of biliary leak. Is any treatment, when you identify, say there is a CBD injury, is it possible to treat it using HIDA scan? No. Is it possible to treat it using MRCP? Absolutely no. Is it possible, right, to treat it using ERCP? In a way, yes, because then we can put a biliary stent in the CBD so that there is no further biliary leakage. That stent will drain the bile into the duodenum and therefore that site of leak may get automatically closed with time. So treatment is possible using ERCP. Which of these is invasive? So HIDA scan is absolutely non-invasive. MRCP is also non-invasive, right? But ERCP, because we have to do an endoscopy and then cannulate the ampulla and then inject contrast, I'll not say it is actually invasive, but because it is an endoscopic technique, you can say it is a minimally invasive technique. And therefore remember, though MRCP is considered to be the most definitive way, or rather the most preferred non-invasive way of visualization of the biliary tree, if you speak to gastroenterologists, if you speak to surgeons, they would prefer ERCP because though it is minimally invasive, it will give you the most definitive assessment of the site of the leak as well as help you in managing the leak by putting a biliary stent. And therefore in this case, the next best investigation would be ERCP. Why? Because a biliary leak is already suspected in this particular case, right? A biliary leak is already being suspected here, right? And therefore MRCP would just confirm that suspicion. It will not give you the site, and therefore ERCP will not only give you the site of leak but also help you in managing it by putting a biliary stent, and therefore ERCP would be the preferred modality here. So look at this image now. This is how an ERCP image looks like. So it is usually an inverted image, right? So you can see that the contrast material is actually appearing black here. It doesn't matter whether it appears black or white. Remember, it is just like a positive and a negative film which is there. These are digital techniques of depicting the data, right? But they will show you the biliary tree. That is what is important. So a question was asked in one of the AIIMS pattern exams. This technique, what technique is this? This is ERCP. So ERCP may be best used for all of the following except. Now let us quickly discuss ERCP and MRCP. ERCP we have discussed is endoscopic retrograde cholangiopancreatography. MRCP is magnetic resonance cholangiopancreatography. ERCP is done by doing an endoscopy, right? We put in a scope, go to the second part of the duodenum, D2, cannulate the ampulla, inject contrast. So it is actually minimally invasive. So it is minimally invasive, whereas MRCP is nothing but an MRI technique, so it is entirely non-invasive. ERCP will give you the most definitive diagnosis for biliary tract abnormalities. It will also help you in planning treatment by dilating the sphincterotomy, putting a stent within it, right? So within the biliary duct for biliary drainage. MRCP has an excellent 3-dimensional imaging advantage. So it can actually give you a 3-dimensional view of the entire biliary tree. These are heavily T2 weighted images. Biliary tree is filled up with bile, that is water. Water appears bright on T2, so it is a 3D image block which can be reconstructed in MRCP. Now, so this technique, remember, ERCP therefore can be used in any abnormality that may affect the biliary tree, isn't it? So therefore, can it be used in assessment of a periampullary mass? Yes, because a periampullary mass is going to cause constriction or narrowing at the ampulla. It is going to cause dilatation of the biliary tree. So ERCP will show that. Can it be used in unexplained jaundice? Yes, because can the jaundice be because of a biliary stricture? Yes. Can it be because of an impacted calculus or sludge within the biliary tree? Yes. And the ERCP technique is going to show you that. How will calculi or stricture appear on ERCP? We will see that in the next few minutes. Recurrent pancreatitis. Why could be the pancreatitis recurrent? Because there could be maybe some biliary tract abnormalities or pancreatic duct abnormalities like pancreas divisum, which is a congenital abnormality of the pancreatic ducts. That is something that can be diagnosed on an ERCPS. Can it be used in acute pancreatitis without choledocholithiasis? What is choledocholithiasis? It is, lithiasis means stones, that is calculus in the biliary duct. If there is a calculus in the biliary duct, ERCP will help us identify that. But if there is pancreatitis without calculus in the biliary duct, so the biliary tree is not affected, and therefore in this case ERCP shows us the biliary tree. Here it is not affected. Therefore it is this condition in which ERCP will be of absolutely no use, right? So in any condition in which the biliary tree or the pancreatic duct is going to be affected, ERCP, MRCP is going to help us. Now let us look at some spotter. See here, this is a dilated CBD. This is dilatation of intrahepatic biliary radicals, that is called IHBR radicals. Why is there dilatation? Because if you look at the distal biliary tree, you see a smooth elongated tapering like this. If you see a smooth elongated tapering of the biliary tree, it is usually suggestive of a biliary stricture. So this is the MRCP appearance. Look at the ERCP appearance. Can you see this is a negative image? I told you contrast is appearing black there. You can see that there is a smooth elongated tapering of the biliary tree. So this is what is suggestive of a biliary stricture. This is also called biliary dyskinesia. Now look at this. Here if you look at the narrowing, the biliary tree is again dilated. Look at this MRCP and this is ERCP, right? It is not an inverted or a negative image, but I said it is just a digital depiction. So positive or negative image does not matter as long as you see the biliary tree well. Look at the dilated CBD and there is an abrupt, more or less abrupt narrowing there. Look at the dilated CBD, more or less abrupt narrowing, and very importantly, can you see CBD is also dilated and the pancreatic duct is also dilated. In what condition are both these ducts dilated? Both of these ducts are dilated in periampullary cancer. So this is what is called as the double duct sign. Double duct sign is dilatation of both CBD and the pancreatic duct. It is usually because there is a tumor at the ampulla. So this is usually a periampullary cancer, right? So this is what is called as a malignant biliary stricture when there is an abrupt narrowing along with a double duct sign. Now whenever there are calculi, remember that they are going to appear as filling defects within the bile, that is fluid, or within the contrast within the biliary tree. So see here, on this MRCP image, you can see the CBD which is dilated. Within the CBD, you can see these filling defects. Look at this dilated CBD on ERCP. Can you see this filling defect within it? So if you see filling defects within the biliary tree, this is how biliary calculi are going to appear. They are the cause of dilatation of the biliary tree here, right? Whereas if you see a patient who presents with non-specific complaints, fatigue, jaundice, pruritus, right, in a known case of ulcerative colitis, 70 to 80% association with ulcerative colitis. And what do you see on MRCP and ERCP image? There are multiple strictures in the biliary tree. Can you see there is a narrowing here, there is a narrowing here, there is a narrowing here, there are narrowings here, there are narrowings here. So many narrowings scattered throughout the biliary tree, right? Something is getting sclerosed along the biliary tree. So this is called sclerosing cholangitis. Yes, what is this? This is called primary sclerosing cholangitis. Multifocal strictures along the entire length of the biliary tree, presenting with fatigue, weight loss, jaundice, pruritus, very strong association of ulcerative colitis. This is kind of a clincher for a diagnosis of primary sclerosing cholangitis. If you see multiple cysts scattered throughout the liver, and you see an enhancing vessel within it, can you see a cyst and a vessel within it, a cyst and a vessel within it? This is called as the central dot sign, right? So this is an MRCP image showing you multiple cysts within the liver. This is a contrast enhanced CT image showing you the central dot sign, that is a cyst, because there is a vascular pedicle traveling within it, within the biliary cyst. This is a feature of Caroli's disease. Remember, this is nothing but a type 5 choledochal cyst. Todani classification of choledochal cysts you must have studied in surgery. So this is type 5 choledochal cyst, Caroli's disease with a central dot sign. This is also a clincher of a diagnosis. Look at this history. A 35-year-old female patient presented with fever, pain in the epigastrium and right hypochondriac area. A HIDA scan is done and shows what? HIDA scan shows non-visualization of gallbladder. See, you can see the liver, you can see the common hepatic ducts, the right and left hepatic ducts, common hepatic ducts, CBD opening into duodenum. The gallbladder should be here and the gallbladder is not seen. Non-visualization of gallbladder on a HIDA scan suggests what? It suggests acute cholecystitis. So this immunodiacetic acid compound or IDA compound, when it is used for hepatic imaging, it is called HIDA scan. This IDA compound, when it is injected intravenously, it is taken up by the liver cells. From the liver cells, it is actively secreted within bile. Now once it goes into the bile, it will show you the entire biliary tree like this. Now in cholecystitis, there is usually a calculus at the GB neck blocking the gallbladder. So the gallbladder, there is stasis of bile and there is infection, that is cholecystitis. Because there is a calculus here, this IDA compound will not be able to enter into the gallbladder. So gallbladder will not be seen, and therefore non-visualization of gallbladder on a HIDA scan suggests acute cholecystitis. See, there is non-visualization of GB, right? This is called acute cholecystitis. A small uptake may be seen in the liver parenchyma adjacent to the GB because there is inflammation, there is hyperemia. This is what is called as the rim sign of acute cholecystitis on a HIDA scan. That is, GB is not visualized, peripheral to the GB, just adjacent to the GB is not visualized, but just adjacent to the gallbladder fossa, a slight increased uptake is seen. This is called rim sign of acute cholecystitis. Now see here, let us look at some classic clinchers of pancreatic imaging. Known case of chronic alcoholic or biliary calculi presents with severe epigastric pain radiating to the back. Now, alcoholic with epigastric pain can be gastritis, but radiation to back is pointing towards involvement of, yes, pancreas. So this could be pancreatitis. There is upper abdominal guarding and rigidity, goes with pancreatitis, and yes, elevated serum amylase and lipase clinches the diagnosis of acute pancreatitis. You look at a CT, you see pancreas is bulky, right? You see this hazy appearance along the surface of the pancreas, maybe small fluid collection along the surface of the pancreas. This clinches a diagnosis of acute pancreatitis. Okay, so for acute pancreatitis, remember CECT is considered to be the investigation of choice. On CT, there is a Balthazar scoring system, there is a CT severity index. Balthazar scoring system gives us a prognostic outcome. CT severity index not only includes the Balthazar criteria but also looks at the pancreatic necrosis within the pancreas, and therefore it has a more stronger correlation with the overall outcome. So CT severity index is considered to be better, right? Now suppose that this particular patient was treated and the patient recovered, patient was discharged, patient comes to you after 6 weeks with a lump in the epigastrium. You do a CT, what do you see? In the region of the pancreas, you are able to see a fluid collection. So what is this? This is a complication of acute pancreatitis seen after a few weeks of pancreatitis. What is this? This is called as a pancreatic pseudocyst, right? Pancreatic pseudocyst, right? The most common site of a pancreatic pseudocyst is usually within the lesser sac. Most common complication is that it can get infected and develop into an abscess. Most common site is the lesser sac of the peritoneum. So this is pancreatic pseudocyst developing as a complication of acute pancreatitis after a few weeks. Now see, elderly patient presents with vague pain, weight loss, obstructive jaundice. So something is obstructing the biliary tree. There is a distended gallbladder, and you do a CT. You see, this is the pancreas. Look at the head of the pancreas, a huge heterogeneously enhancing mass lesion that you see at the head of the pancreas. In an elderly patient with obstructive jaundice, with a distended GB, this suggests there is a CA of the head of pancreas. Though the investigation of choice, or here the in diagnosis we have made on CECT, the overall investigation of choice for staging is going to be a PET CT, because it is going to help you detect the staging or detect the spread of this particular tumor. So this is CA head of pancreas. Now conventionally on barium meal studies or barium meal follow through studies, when there was a mass close to the head of the pancreas, it used to cause widening of the duodenal C loop. So this is called widening of C loop of duodenum. This impression on the medial wall of the duodenum giving a reverse 3 kind of an appearance. This is what is called as the reverse 3 sign of Frostberg, reverse 3 sign of Frostberg. And on MRCP, right, we have already seen both ducts are going to be dilated. This is the CBD, this is the pancreatic duct, both are dilated in a CA head of pancreas or periampullary CA. This is what is called as the double duct sign. So this is what is called as the double duct sign. Yes, now let us quickly discuss few investigation of choice clinchers. They can be asked to you either as a factual question or as a part of a clinical scenario where the investigation, where the history is given, clinical profile is given, and the examiner is asking you what is to be done next. So for GB calculi or cholecystitis, the investigation of choice, remember, is USG. That is because concept is biliary calculi have poor calcium content, and therefore they may not be seen well on a CT or a X-ray, and therefore USG is the investigation of choice. For focal liver lesion characterization, though they can be detected on USG, the best investigation is a multiphasic CECT, multiphasic CECT or a triphasic CECT. To distinguish between hepatocellular carcinoma or METS is again multiphasic CECT, right? In order to detect liver mets in a known primary, right, it is usually PET CT. So distant metastasis or liver metastasis in a known primary, it is usually PET scan or PET CT. Remember, gold standard investigation for imaging of the biliary tree, in most cases it is also the investigation of choice, remember, is ERCP. Best non-invasive technique, if they ask you, for imaging of the biliary tree, it is usually MRI. CP. Okay, so these are a few clinical pearls or insights that will help you crack some questions in the upcoming exam. Remember friends, some people dream of success while some people, the others, usually wake up and work hard for it. I want you to be a part of this group of awakened people. Dreaming is all right, but as APJ Abdul Kalam sir had said, that dreams are not what you see when you are asleep. Dreams are those that actually do not let you sleep at night. They keep you awake so that you work hard towards your dream. Let us get one step closer to your dreams together through these sessions. All the best.